Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN, Healthy World, Healthy Nation, Healthy You. I'm Nancy Valentine, PhD and registered nurse, and this show is for you, the healthcare consumer. And today we have a topic that I think you will find both interesting and intriguing, because I bet very few people watching this show will have any background on this particular topic. I'm going to tell you what our title is, and then I'm going to explain what it means. We are going to be talking about applied health economics and outcomes research. That's a mouthful right there. What consumers will need to know to make future care and purchasing decisions. And our guest today, who I will introduce in a moment, is Dr. Joseph Jackson from the School of Population Health at Jefferson University. But let me just tell you a little bit about what this topic entails. Often when you go to the doctor and the doctor is prescribing a particular care regime for you, a medication or something that you need to do to help yourself become healthy again, you're not thinking about the science in back of that. Like, how did they come up with this plan? Or why is this drug better than another drug? You just sort of take it on face value because you trust the physician or other members of your treatment team, and you feel that that is the best way to go. But actually, what we're going to talk about today is the science in back of that. Because the science that really gets people to the point where they know what to do, they know what the best treatment entails, really requires a whole team of people, for which Dr. Jackson is a leader in his field, and he's going to tell us about that. So let me tell you a little bit first, to tee this up, what applied health and economics and outcome research really entails. It is an academic discipline unto itself. So it's not medicine, it's not nursing, it's a whole discipline unto itself. And it really is looking at whether a product, in this case a drug or a service, a particular kind of operation, does it really work? And what are the benefits that it has to patients? It also looks at comparison. Is drug A better than drug B? Or is a particular intervention surgically better one way versus another? And in order to do that kind of work, one has to have the scope of interest, the ability to take these various studies and compare them to one another. And that's what our discussion is going to be about today. Because when you listen to this show, what I hope you will come away with is more knowledge and more curiosity, so that when you're talking to your doctor, you can ask, is this the best drug for me? What are the other choices? What could I do instead of what you're recommending? Now, this is not to become controversial. This is to become informed, so that you can have a very adult-to-adult conversation with your treatment team about what options will work best for you. So, what we are going to talk about today is what makes medicine scientific. What are these outcome research projects doing? What do they look like? And how do we study the studies that are out there in order to get the best outcome for people? The second is what works and at what price, because you're going to be very interested in this as we move along in healthcare reform, because through co-payments and direct costs, you may be paying for some of these treatments, and you will be very interested in knowing what works best. And then I think we're going to look at comparisons. Often the comparisons that Joe will talk about will be between traditional medicine and maybe some case alternative medications or medicines and other approaches to healthcare. And what is best? And he has done the science, and he works with other people that have done the science that really gives us answers to those questions. So with that very long introduction, I'm now going to get to our guest today, who is a delightful person who I met about 6 months ago when he gave a presentation at Jefferson School of Population Health. And I was so impressed with his ability to translate complex concepts down to people. I thought that he should be on this show, so I invited him. So let me tell you a little bit about our guest, Dr. Joseph Jackson. He is a PhD, not an MD. His PhD is in School of Pharmacy, and he also had a concentration in health administration from the University of Mississippi. He is now the program director for the Applied Economics and Outcomes Research here at Jefferson University in Philadelphia, where he is responsible for the school's Master of Science degree programs in this field, and he also works with the PhD population. So he is not only doing research and looking at these outcomes, he is really training the next generation of scientists in order to do this very important work for us. So Joe, thank you so much for being with us today.
Thank you, Nancy.
Yeah, it's really a delight. And I didn't mention that you also worked for 30 years in the pharmaceutical industry. So you've got a very rich background.
That's where I cut my teeth.
Well, I guess with 30 years worth of experience, you've got a lot of teeth to cut.
Yeah.
Well, first of all, since most people are just trying to wrap their minds around what I just said, tell us how you got involved with this field, because this is not an old field. This is a relatively young field in the whole scheme of things.
Well, it is interesting because when I came into the pharmaceutical industry in 1981, I had tried a stint in government and I had tried a stint in academia, and I elected for the other option, the pharmaceutical industry. And when I came in with a degree in outcomes research from a school of pharmacy.
I see. Okay.
I was interested in value before value was popular.
Right. Now tell us again what value is, because people are going to be hearing this term tossed around a lot in healthcare reform lingo. So explain value to our listeners.
Well, when I think of value, I think first about efficacy or effectiveness.
Okay.
The outcomes, if you will.
Like, does it work?
Does it work? Because no matter what you pay for something that doesn't work, it's not going to be cost effective because it doesn't work. So I think of the outcomes as the noun and the economics as an adjective that you link with the noun. So if you know that something is working well and it has a good economic profile to go with it, in other words, you have fewer of the bad outcomes, more of the good outcomes, and not too much on the price, then you're going to have a good value.
Right, right. Okay, so that got you started. And so you were really an early pioneer in this field.
That's right. When I came, my field was not in existence. So I actually started in sales and marketing.
Interesting.
And it was through that experience that I started to work with the doctors and the drugs that we had available to us and fit those into the armamentarium of the doctor. Well, it was kind of interesting because during that time, the DRG program was passed.
Now, DRG would be?
Diagnosis-related groups. Those are bundles of kinds of diagnoses and procedures that dictate what a patient gets paid for in the hospital. So if you have, say, a hysterectomy, and the DRG payment is $4,000, and you spend $5,000 on that patient, then the hospital would lose $1,000.
So what I think Joe is reminding us, because I lived through that era as well, and that was quite a while ago, that was really one of the revolutionary steps in really trying to curb healthcare costs. And at the time, it was in the 80s that I was director of nursing at Boston City Hospital. And I remember the shock waves that went through the whole healthcare community at that time with these diagnostic-related groups, DRGs. And what I think you're explaining to us is that people then had to realize that if they were going to give care for someone with diabetes or a heart condition or whatever, they had to do it within a certain range of cost. They couldn't just order anything and everything. So they really were getting curbed by their costs. So continue. So when you were out there with the drugs, you start to see that they're going to look at drugs that cost less.
That's exactly right. And we happened to have one of the new antibiotics at that time. And our antibiotic didn't require lab tests to find out whether or not the drug was in range. And it was safer than some of the other drugs. So it didn't cause, say, ear toxicity or eye toxicity.
As a complication.
Or kidney toxicity as a complication. And so we were able to work up a program that looked at the total cost of the drug in terms of good outcomes and minimal side effects, and was able to demonstrate, along with a surgeon from the Mayo Clinic that I worked with when I was this was at Johns Hopkins.
Okay.
And he had trained at the Mayo Clinic, and he worked with me on a little Lotus 1, 2, 3 spreadsheet.
Wow.
And we sort of put it together, put all the numbers together, and it was a way to show the full value of the drug, not just the price of the drug, not just the price of the test,
Right.
and so on and so forth.
Right. But I think the point that Joe just made is really important for us today, because 30 years ago, what I heard him say is that there was knowledge about what was maybe the better drug under a certain circumstance, but until there was a little bit of a crush down on that money side of the equation, people didn't pay as much attention to it. They didn't really feel like they had to do it one way or the other. Is that correct?
That's exactly right, Nancy. In fact, let me bring it forward to today.
Okay.
Our healthcare system is built on the notion of fee for service.
Right.
So
which again, translate that, not everybody would know that
Well,
term.
fee for service, when you go and visit your doctor, the doctor will get a set fee for that amount. Whether the doctor stays with you for 5 minutes or 35 minutes, he will, for the most part, or she will, for the most part, get a set fee.
Right.
And so there's an incentive to do things when you have a fee-for-service system. Same thing like doing an X-ray or an MRI or doing a procedure like a total knee replacement or a total hip replacement. These kinds of fee-for-service things mean the more you do, the more you get paid.
Right.
Well, in the future, we're probably not going to have as much of that.
Correct.
We're going to have more group care, and the doctor will get paid to manage you through all of your illness. So if you have a heart condition, the doctor will need to find out what works best to alleviate and manage that heart condition.
Right. And I think this is another key point which is really worth spending a couple extra moments on, because fee-for-service is really like a production line. You know, it's as if you went in for your car, not to use this as an analogy to a complex person, but just to simplify it. If you go in for, new tires, that's a cost. If you go in for an oil change, that's a separate cost. There's nobody looking at your car holistically and saying, what do I need to do at the cheapest price to make Nancy's car work, which, believe me, my mechanics are really challenged by that. So with the analogy here with people, what Joe was telling us is that physicians and you as the patient and family are really going to have one set price of what it's going to cost to really get you well. So it's not just what they're going to do, like this blood test or this particular drug. They're going to have to look at you as a fully integrated person. All the aspects that you have to deal with in order to get healthy and to remain healthy. And they're going to have to wrap that together. And that is why this whole topic of outcomes research, which in the beginning of our conversation just a few moments ago, seemed like it might be diffuse, or how does that really work, or why would we even be interested in that, to this is going to become the lifeline to really determining what works within a set range of expense. Well, not because the government doesn't want to spend more money. It's not even a political situation. It's really about you and how much care and treatment do you need. You want the least amount of treatment to get the best outcome. And we're back to this discussion about outcomes research, because it's having to do with what works best and at what price. So that was a big lesson learned for you when you really worked in Johns Hopkins on that project.
Well, that's exactly right. And the DRG was the kind of reimbursement system where you only got so much for, let's say, a heart attack. And so you had to make the most of that money that you were allocated. And that means picking your interventions carefully,
right,
so that they have ultimate value.
Right. Now, so fast forward to today, do you see physicians and other members of the fully integrated treatment team more attuned to outcomes research now?
Absolutely.
Okay.
Absolutely. The discipline, I quickly realized that on the marketing and sales side, my management would come to me and say, Joe, that was a really nice value argument you put together. Do that again. And they would say, I'll give you a set of studies and you take them home and over the weekend analyze them and bring them back and and then we'll have a cost-effectiveness argument. And I said, wait a minute.
These would be the doctors telling you that?
No, my company.
Oh, your company. Oh, okay.
My company. And I said, wait a minute. How the studies are designed makes a difference. And if you design them so that you can analyze the value, it's much easier than getting it after the fact and trying to put together a good argument. And so I quickly moved into clinical research. And I spent most of my career in clinical research.
That's interesting. Now, I just have to ask you this. Did you have a PhD when you were in sales?
I did.
You did?
I did.
I think that's unusual.
Nobody cared about costs back then. You just can't imagine. Everything was cost plus reimbursement. So no matter what the doctor did, they got paid for with a little bit of plus for profit. And so all of a sudden, when the DRG program came in, that was the first time limits were put on. And all of a sudden, you didn't just automatically get profit.
Right, right.
And we have progressively been moving toward that inexorably for 50 years almost, 30 years, whatever, 1980s, 30 years.
Right, right.
And so it's this notion of trying to do the best for groups that really brought this to the fore. And maybe you don't realize it, but behind a doctor's practice is usually a group of well-meaning administrators and doctors that think about value. So do they know what a formulary is? A formulary is kind of a preferred list of options.
Right.
And you make the kinds of arguments about value that I'm talking about to formularies so that doctors will be informed what's the best path for a given drug.
Right.
What kinds of patients will they get ultimate value in, and so on and so forth.
But I mean, I have to just say, as a sidebar to this whole conversation, I'm intrigued that you were in sales and then the light bulb went off and you said, I'm moving out of sales and I'm getting into the lab.
Well, that's right.
That was pretty dramatic.
Well, it was dramatic, but I knew I wanted to be at the core of producing value for the population at risk. And I can tell you, I worked on the early statin drugs.
Okay.
And statin drugs, at one time, people didn't know how important cholesterol was in having a heart attack.
Right.
In fact, I heard it said by one doctor that too many trips to the Golden Arches get you ever closer to the pearly gates. and so cholesterol builds up on the arteries of the heart.
Right.
And then the blood can't get through and feed the heart, so the heart doesn't work as well as it should.
Right.
Well, statins are a way of alleviating some of that cholesterol burden, and so the blood flow through the heart is that much better, and therefore you maintain a healthy system, a healthy circulatory system.
Right.
Well, people wondered, these statin drugs are fine, but they cost a lot.
They certainly do.
You know, they just went generic a few years ago, but Lipitor was the biggest statin drug and sold something in the neighborhood of $12 billion a year. And when it went generic, all that disappeared.
Right.
So statin drugs are the kind of drugs that people should take if they want to maintain health and not get into trouble with a heart attack or a stroke. See?
Right.
And we can do cost effectiveness equations to tell you how often those heart attacks occur and how much you pay for the drug and how much you're able to offset the costs of heart attacks and therefore bring the price of the drug down.
Right. So in your work, even though outcomes research really can go around a lot of different topical areas, like I said, it's not only pharmaceuticals.
No. I'll give you an example.
Go ahead.
A orthopedic surgeon at Rothman Institute approached me recently, and they said there's 4 types of hips. There's metal on metal hip, and there's metal on plastic, and there's ceramic on ceramic, and there's ceramic on plastic.
Are they all different manufacturers, by the way?
I'm not sure.
Okay.
I'm not sure. I think the hip technology has been evolving.
Right, that's true.
And she wanted to know, she wanted me to work with her to say, which of these strategies would be the most cost effective? And it turns out that they're putting hips in, not just into older people like they used to. Now they're starting to put hips into younger people.
Right.
And so if the metal on metal starts eroding, then you have to replace the hip. So that's a revision.
Right. So that's value over time.
That value over time, and it costs money.
Right.
Right? And it influences the patient's health.
Right.
Ceramic is probably best because it doesn't wear down as much, but let's say you get in a car accident, the ceramic hip can shatter. Well, how often do people get in car accidents? Not very often with hips.
So what's the cost-benefit ratio?
So you would start weighing up all the options. How long does the hip last before a revision is needed, and so on and so forth. Jack Nicklaus has a hip. All right, he needs a hip. His job, golfing, requires a sophisticated hip movement.
Right.
So for him, having an artificial hip extended his career. We might, in outcomes research, say he was able to maintain his work environment because of the medicine that he got, or the intervention that he got.
Right.
And so we look not only at the costs associated with the therapy, but also the influence it might have on the person's life.
Right. But I think it's really exciting what Joe is sharing with us, because what I hear is that physicians and a PhD trained person with a lot of life experience is a great combination to raise the right questions. Before you can really figure something out, you have to have the curiosity and you have to ask the right questions. Then, as he said, the design of the study, how things are going to be compared. So you're comparing apples to apples, and you're not getting it so mixed up that by the time you get to the data at the end, you can't make any sense out of it. So they are very carefully structuring these comparative studies so that when they really come to the conclusions, they're sound, and then they can go back to the data to really have the argument that this is really substantiated. So I think that that's really good. But I also can envision a world, just to use the hip example, where this becomes more transparent to the consumer.
That's right. Almost like a Consumer Report.
Absolutely. Why not? I mean, instead of just, saying, okay, I'm going to a good orthopedic doctor, we tend to think of you've got to go to the right technician, the right person who has the right skill set. Well, that's really important. But what you're saying in this example is they have to be working with the right materials.
Well, that's right. And it turns out that sometimes in some of these procedures, the number of times the surgeon does the procedure indicates their success in doing it.
Right.
Maybe we're not talking just hips here, maybe we're talking a more complex procedure. And the fact of the matter is, sometimes if you go to the surgeon that has a lot of experience in doing these, you get a better result than going to somebody who's only done it a few times.
Right, right. In fact, many years ago, as I've shared on some of the other shows, I was the chief nurse executive for the Department of Veterans Affairs nationally in Washington, D.C. And the Department of Veterans Affairs really had to confront this in the 90s or mid-90s, when they really took a look at all the surgical programs. We're just going to use that as an example. This was not the only example. Because the VA is vast, there were 173 medical centers at that time, and many of them were running surgical programs because they were training surgeons in all these different neighborhoods, communities rather, throughout the country. But then they started looking at the outcomes of these surgical cases. And they found exactly what Joe just said, and that is, if you didn't do very many cases, your outcomes tended to be worse than the people that were churning out a lot of the same cases, because it's like anything. A lot of dexterity is involved in surgery, and a lot of mind sharing that goes on, so the more you do, the better you get, like anything else. So they had to really bite the bullet and close down many surgical programs throughout the United States. And people were very unhappy about it because they saw it through a different lens, like their surgical programs were being lost, or they were losing their jobs. I mean, there were definitely job shifts and losses around that. But that was a good example of really taking a policy approach, which was what was in the best interest of our veteran population, and we really did have to do that. If you were to give some advice to our listeners around how they could get more tuned in to the outcomes research and what it means for them, just give us a couple examples.
Well, let me say first that a few years ago, in the journal Nature, which is one of the oldest journals that exists for scientific literature, Nature, two deans, Howard Hyatt from Harvard and Lee Goldman from UCSF, University of California, San Francisco, put out a one-page article called Making Medicine More Scientific. And in that article, they reviewed what they called the evaluative clinical sciences, which is really outcomes research.
Right.
So the science that most doctors rely on is published in the best journals, the New England Journal of Medicine, JAMA, the Journal of the American Medical Association, Annals of Internal Medicine, Lancet in the UK, the British Medical Journal. These are the best journals in the world. And when they publish good science, doctors pay attention.
Right.
And so one of the first things you have to do to understand a little bit about medicine is to know where the science comes from.
Right.
And how important it is. And so in some of these reviews, people talk about that. I shared with you the medical letter. The medical letter is a group of what I would call very dispassionate scientists who sit and look carefully at the literature and come up with a reasoned analysis of a given area. And they pay a lot of attention to those kinds of things.
Right.
A formulary committee will sit and review all of the drugs in a given area, and they spend a lot of care and attention to try and come up with their recommendations. So you really, the average consumer needs to kind of ask the physician, is there good science backing this intervention?
Right. Hey, listen, I think if you use that question, you're going to put everybody on notice just asking them that alone, because they'll know you have watched this show and that you've already had, you know, some background in knowing how to ask the right questions. And I think your doctor and other treatment team members will be delighted to answer that for you, because they want to have you engaged. They want you to be asking these questions. So I want to thank Dr. Joseph Jackson for being with us today, because I certainly have learned more about outcomes research than I knew before I listened to this show, and I did know something about it from my own work. But I have really a better appreciation for where it's going to go in the future, and I love the idea that it's going to be more transparent to you, the consumer. So I hope that you will take some time, think about what you learned today, and share it with other people, and have that conversation with your doctor, even about minor things. It doesn't have to be a hip surgery or something, you know, very profound. It could be, you know, some kind of medication that is being ordered for you as part of your primary care visit. You can raise the question and ask for more of the science in back of that, and you might even get some papers to take home and take a look at and read. And maybe this medical letter in time will be translational, where it will be written in a consumer way as well as for the scientific community at large.
Nancy, let me just say that Annals of Internal Medicine writes a segment about their studies for the consumer.
Well, we're gonna do that in another show. I'm going to ask Dr. Joseph Jackson to come back, and we're going to go through that so that you will have a PS to this one, because having those scripts is really so important. So I think that we'll end this show today and just say I thank you so much for being with us, you, our audience. This consumer-oriented show is for you. I hope you enjoyed it, and I hope you learned something, and I hope you can catch this and other shows on my website, www.drnancyrn.com. And remember, with health, all things are possible. Thank you very much. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening, and join us again. And remember, with health, all things are possible.